Live. You can also find us online at mainepublic.org. It's 2 o'clock.
Maine Public, we can hear the audio coming through on your line.
What you want? What? You like that kind of soup?
Okay. Well, good afternoon, everyone. I'm Nirav Shah, the director of the Maine CDC. I'm delighted to be able to join everyone this afternoon to provide an update on where we stand with respect to COVID-19 across the state of Maine for today, the first briefing of 2021, Monday, January 4th. I'll start by talking about where we are in terms of the epidemiology of COVID-19, and then talk about where we stand with things like vaccinations across the state before turning things over to our colleagues in the media. I begin this afternoon's discussion with an update on where we stand with cases. Right now across the state, Maine CDC has received reports of 25,968 total cases of COVID-19, an increase of 376 cases since yesterday. Of those, 29,998 are confirmed and 3,970 are probable cases. Right now, across the state of Maine, 186 people are in the hospital with COVID-19, 51 of whom are in the ICU, and 23 of whom are on a ventilator. Cumulatively, 1,107 people have been hospitalized. Among all of our cases, 2,837 are among healthcare workers. I'm going to turn now to talk a little bit about where we are with testing. Right now, the 7-day weighted PCR positivity rate in Maine stands at 6.3%, and the PCR testing volume stands at 440 PCR tests for every 100,000 people. Similarly, the antigen positivity rate stands at also 6.3%, and the antigen testing volume stands at 114 for every 100,000 people. I'd like to take a quick second to pause to talk a little bit about what those positivity numbers mean, specifically how and why they've changed in recent weeks. The first thing to note is that the increase in positivity rates over the last 3 months are proof positive that the virus is still very much with us. But you'll note that just in the recent few weeks, that positivity rate has gone up significantly. 14 days ago, one incubation period ago, the PCR positivity rate in Maine stood at 4.15%. Today, it's at 6.3%. Similarly, 2 weeks ago, one incubation period ago, the testing volume in Maine for PCR stood at 537 tests for every 100,000. Today, it's at 440. At the same time, we've had a slight increase in the number of new positive lab results that are generated every day. Right now, that number is at 355 on a 14-day moving average. In the 14 days prior to that, it was at 336. That's a lot of numbers. What does all of that mean when taken as a whole? Much of what has driven the increase in positivity rates over the last 2 weeks has not been exclusively an increase in transmission, although that has occurred. That has been coupled with a decrease in the number of tests that are being done. Now, there are a number of reasons why there are fewer tests that are occurring right now. One of the ones that I want to touch on and we'll expand upon in just a moment, that is not the case, is a reduction or contraction in our capacity to do tests. Indeed, the Maine CDC laboratory remains as busy as ever. But there may be other reasons why folks are not seeking testing. One of which, of course, is the holidays. What may have been a top priority for folks who were feeling a little under the weather 2 or 3 weeks ago during the holiday season may not be so much of a priority. There are also reasons that have to relate to things like schools being out, so on and so forth. My team and I are starting to look into why the number of tests being conducted has started to go down over the last 14 days as compared to the prior 14 days. But another thing that stands out is that if you zoom out back to around Thanksgiving, testing volume started decreasing back then, presumably with college students not being in school and on campus, and has continued to decline ever since then. So we're taking a look at why all of these factors, all taken together, have resulted in a decreased positivity rate. But the bottom line here is that although there has been some increased transmission in Maine, for sure, much of what is driving the increase in positivity rates is that denominator, the number of new tests. And that seems to have shrunk faster than the number of new positive cases has gone up. I'll have more to talk about that as we continue our analysis. I'd like to turn now to talk about a couple of outbreaks that Maine CDC have opened that are of note that we have opened since the last time we spoke last week. Those outbreaks include, among others, the Northern Light Heart and Lung Rehabilitation Center in Presque Isle, where we are aware of 4 cases. The Marshwood Center in Lewiston, where we are aware of 18 cases. Mercy Home, also in Aroostook County, where we are aware of 9 cases. Mount St. Joseph's Rehabilitation in Waterville, where we are aware of 4 cases. Northern Maine Medical Center in Fort Kent, where we are aware of 6 cases. And Schooner Memory Care in Auburn, where we are aware of 4 cases. I'd like to take a second here too to just note that many of the new outbreak investigations that Maine CDC has opened in the past week have been in Aroostook County. We remain concerned about the increased number of cases that are now generating an increasing number of outbreaks, particularly in Aroostook County. I've asked our team of epidemiologists and disease investigators to pay special attention to what's happening in Aroostook County so that if we detect outbreaks, we can attempt to intervene upon them as quickly as possible so that they do not get out of control. And finally, I'd like to talk a little bit about where we stand with respect to vaccinations. As of this morning, a total of 33,425 vaccine doses have been administered across the state of Maine in the first few weeks of our vaccination efforts. As of this morning, 18 of those 33,425 have received not just their first dose, but now their second dose. As we move now, being in that 4th week of vaccinations now, we expect to see more and more people who have not just received their first dose, but now also their second dose. This is great news, and for me was a great piece of data on which to begin this new year. In addition to that, among those 33,425 people, nearly 1,600 of them are among EMS clinicians. Another good piece of news, making sure that we can protect our first responders in the field so that they can stay safe as they are out there doing the work of keeping all of us safe when we need them the most. And finally, before I turn things over to our colleagues in the media, I'd like to just touch on a few things. The first was an observation. It was exactly 1 year ago today on the calendar that I first met with my team at Maine CDC to discuss what, at that time, was an emerging and unique form of pneumonia that had been detected and described in central China. Since then, 1 year ago, we have come a long way. both with good reasons and sad reasons. I'd like to take a moment to just take a look back at what Maine CDC did in 2020 by offering a few numbers. Let's first start with some numbers that we haven't talked about in a while, and that is the operations of our public health emergency preparedness team. This is the team that, among numerous duties, has been primarily responsible for providing PPE and testing materials and supplies to healthcare facilities across the state. As of last week, that team had filled over 5,500 unique orders for PPE, totaling, get this, 4.5 million items in total that we have shipped to healthcare providers and other recipients. This includes PPE like N95s, surgical masks, gowns, and gloves. It also includes things like swabs to conduct the COVID-19 test, as well as the vials of transport medium to make sure that they can get to the laboratory that they're going to. All told, in 2020, Maine CDC's Public Health Emergency Preparedness Team delivered over 4.5 million items to providers and groups across the state. Our laboratory, the Maine CDC's Health and Environmental Testing Laboratory here in Augusta, similarly had a record-breaking year. That laboratory alone in 2020, starting in March, performed 226,000 COVID-19 tests. That is a multiple number higher than the total number of tests that entire laboratory does for every single disease in a typical year. They blew through that by multiple numbers just based on 226,000 COVID-19 tests just in 2020 alone, starting in March of last year. As a state, all laboratories that report their lab results to Maine CDC conducted now about 1.1 million tests for COVID-19 throughout 2020. That's nearly one test per person across the state that all laboratories, including the Maine CDC laboratory, conducted and reported up to us. Similarly, our epidemiology team answered over 20,000 requests for consultation, 20,217 to be exact, from individuals and healthcare providers across the state who called us specifically to ask questions on the best way to approach a COVID-19 situation. That was augmented by our colleagues at 211, who answered over 50,000 phone calls from Maine people to answer their questions around COVID-19. I would like to start this year by taking a look with that look back on 2020, by thanking the hundreds of people who made those numbers what they were, to make sure that every single person in Maine had information, supplies, and the wherewithal to manage COVID-19 across the state. But this year is just getting started. In the past year, since when Maine CDC began our work on COVID-19, the virus has now spread around the globe and has impacted all of us in innumerable and myriad ways. Here we are 1 year later with not one, but 2 vaccines in the United States and additional vaccines now available across the globe. I'd like to take a minute to talk about where we stand with respect to COVID-19 on 2 fronts. The first is a new strain of that virus that is itself making its way across the globe, and then take a moment, as I've tried to do recently, to answer some of your questions that you have sent to us around the vaccine and vaccination. Let's start with this new variant of COVID-19. As much as I regret having to say this, just when so many of us need and deserve a break from COVID-19, the new variant strain of COVID-19 is concerning. It is likely a matter of time before it arrives in the Northeast, let alone in Maine. And as a result, I want everyone to be aware of this and to start preparing for it right now. Here's why. All viruses mutate, and those mutations result in new strains that vary in different ways from their ancestor strains from a couple of weeks or a couple of months ago. That's just what viruses do, and that's what they're going to continue to do. These new variants are called strains. Most coronavirus strains don't fundamentally change how the virus behaves or affects us. But in recent weeks, at least one newly recognized strain that has now been taken to calling the B117 strain has been shown to have several changes that are changing the way that the virus behaves in important ways. This new strain has been found across many countries, most notably in the UK, as well as in at least 3 states, Colorado, California, and now Florida. Here in Maine, we have been actively looking for that new strain in partnership with the US CDC and our colleagues at the Jackson Laboratories. We have not found it in Maine yet. Although it may very well be present at low levels and thus undetected, we continue to actively look for that strain, even though we have not yet found it. Although, as I mentioned a moment ago, it is likely a matter of time before it arrives here. Once that virus hits a critical threshold, it will start to begin spreading even more rapidly unless we slow it down. The most important thing to know right now about this new strain is that it seems to spread more easily, by which I mean more quickly, than other strains. To put that differently, it seems to be more contagious. That means that if you are exposed, your risk of becoming infected is higher with this new strain than as it was compared to previous strains. If you are infected with this new strain, you are thus more likely to spread it to others. There are, however, some signs of good news on the horizon. People infected with this new strain don't seem to have more severe illness than as with the other strains that are currently circulating. In addition, it's also likely that the vaccines that we currently have and that are being developed will still be highly effective against this new strain, although that needs to be monitored. But here's the thing. Even if this rate of hospitalization is higher than, is similar to rather, even if this rate of hospitalization is similar to the current prevailing strain, if it means that more people are infected by it, there will just mathematically be more hospitalizations as well, sadly, as possibly more deaths. This may increase the suffering in our communities as well as continue to prevent challenges to our healthcare systems. In addition, faster spread leads to more people being infected in a shorter period of time. And that's concerning as well as dangerous because it could mean that there are more outbreaks. But here's the other thing that everybody needs to know right now in order to prepare for this possibility. The variant spread, this new strain, spreads the same way as do other current COVID-19 strains. It's just better at spreading. But the tools that we have used thus far, face masks and physical distancing, are just as effective at preventing infection by this new strain. And given how much more quickly it seems to spread, those tools are more important now than they've ever been. No virus can make you sick if it can't get to you in the first place. And face coverings plus physical distancing significantly reduce the likelihood that the virus will get to you in the first place. What can you do right now? You can be prepared to double down on those same bedrock principles: face masking, physical distancing, decreasing the number of interactions you have in large group settings, limiting your contact with folks who aren't in your bubble always wearing a face covering when you are around non-household members, indoors or outdoors, avoiding crowded, poorly ventilated indoor spaces. All of those things are things that are more important now than they ever have been. Ultimately, a vaccine will be our best defense against this strain and all other strains, but right now, it cannot be our only defense. I'm going to take a moment now, again, before I turn things over to our colleagues, just to answer a couple of really quick questions that have come in about the vaccine overall. Some of these are in keeping with what I just talked about. Now that more people in Maine are getting their second doses, one of the questions that's come into us is, after I get both of my doses of COVID vaccine, do I still need to wear a mask and take precautions? The answer is yes. Why is that? Well, that relates to one of the other common frequent questions we've gotten, which is, can I still transmit the virus even after I've been fully vaccinated? And the answer is, we don't know yet for certain, although there are multiple early signs that point to the answer to that question being no, meaning that after you've been fully vaccinated, your likelihood of harboring or transmitting the virus seems to go down significantly. But at this time, we don't know how significantly and whether that gets you to a level where you're not a risk to others. And for that reason, at this time, even after you've been fully vaccinated, Maine CDC and the US CDC continue to recommend face coverings and physical distancing until we know more. And finally, one of the questions that's come up quite a bit is, are there any differences between the Moderna and the Pfizer vaccine such that I should ask for one over the other? Now, certainly there are differences in how those vaccines are stored and handled. And we've talked about that, the ultra cold freezers and such things. But in terms of how they work and how well they work on different populations, the two vaccines are largely identical. And that's why I continue to recommend that the best vaccine for you is the one that is closest to your arm. So with that, we're going to turn things over to our colleagues in the media. And to kick us off this afternoon, I'd like to turn to Patrick Whittle.
Thank you very much, and Happy New Year. I listened to your appearance on Maine Public earlier today, and you mentioned that uptake among recipients so far has been pretty good. I would love it if you could sort of expand on that a little bit, and sort of what the state's strategy is for kind of trying to avoid some of the hesitancy that we've seen in other states. And so as a point of clarification, were you talking about healthcare providers, long-term care residents, or both when you said that?
Okay, so great. Thanks, Patrick, and Happy New Year to you. Let me start with the hesitancy piece. In recent days, some health officials and some governors have reported that, for example, in some facilities that have started receiving vaccines, say long-term care facilities, the uptick rate among staff members, in one example, was 50%. We're trying to get a better sense of what the denominators are so I can provide more numerical or empirical clarity around that. Admittedly, what I've got right now are data that have come to us from hospitals who have reported that the uptake rate among their staff have been on the 70 to 85, in one case, 90% range, which is great and where it definitely needs to be, although I'd like to even see it as high as possible. The rates, so I don't yet have great data on the uptake rate among staff at long-term care facilities, but again, in conversations with the vaccination teams that have been deployed by the pharmacies, they have, again, somewhat qualitatively reported that uptake among residents has been extremely high, and among staff, it has also been high. But I don't have numbers around that. I hope to have better numbers around that soon. We've been working with hospital leadership and healthcare providers of all different stripes across the state to get them toolkits and FAQs for their healthcare staff to answer some of the questions that their staff may have had around vaccines. We started pushing those out even before vaccines arrived in Maine. I think that is one among many reasons why uptake rates among healthcare providers in Maine have been very strong.
Thank you for that. Just to clarify, you mentioned that you're seeing reporting rates of 75, 85, 90%. Is that from hospitals or is that from all facilities?
No, that is specifically from hospitals, and they're specifically from their vaccine coordinators or their medical officers who are deeply involved in the vaccination process.
Okay, terrific. And that's more or less on target?
Yeah, I mean, the higher the better, right? So the target, the goal is 100%, but I want to be clear, not every hospital can or should vaccinate all of their staff in one day because folks can generate a small fever after vaccination, so on and so forth. So not until all the data are in do I want to make pronouncements about whether the number of uptake at a hospital has been where it's needed to be or whether it's got room to grow, because hospitals are still continuing to work their way through all of their personnel right now.
Great, thank you very much.
Yep. I'm going to turn things over to Megan at WMTW next.
All right, Dr. Shah, thank you. This kind of goes off of Patrick's question as well. So you mentioned 1,000 EMS clinicians have been vaccinated. Does that mean that we've moved into phase 1B? No. Okay. So can you maybe give a timeline on that? And are there specific factors that make giving that kind of timeline difficult, like targeting goals? What are those factors? If you could answer that, that'd be great.
Sure. So first, Megan, just a numerical clarification. As of this morning, the number of EMS clinicians was nearly 1,600 by this time. It is probably over that 1,600 threshold because we know that they were continuing their vaccination efforts.
Okay.
So that number again is 1,600 at least, if not higher. Tomorrow I'll have a more updated number. And EMS clinicians were always considered part of the nucleus of 1A. So that for very first group alongside emergency department staff, ICU staff, et cetera. So given the role that they play in our healthcare infrastructure and the fact that they are multiple times per day exposed to individuals whose COVID status is unknown, that's why we put them in that category. Okay. They're critical and their exposure risk is high. Now, in terms of where we go from here, I think, again, it's important to note, Megan, we are still squarely in the midst of 1A. Hospitals have made great progress in vaccinating that first group of emergency department, emergency EMS clinicians, et cetera. We're now, as we talked about last week, expanding to the next circle. That includes outpatient providers, those who may not be regularly affiliated with the hospital, but are nevertheless part of 1A, part of the healthcare system. That probably is going to take us well through this month. Now, as much as I would love to be able to provide a projection, if not a hard and fast date, about when we'll expand and move beyond 1A, what governs that almost in its entirety is the supply of vaccine. We've talked over the past 2 weeks about how the supply of vaccine that Maine has received, that all states have received, is not what we were hoping for. It is invariably and undoubtedly a difficult process, but we can only move as fast as the vaccines that we are getting come in. And so what governs that, the brake on that system, is just the throughput of supply of vaccines.
Can I follow up and just about phase 1B? If the older Mainers in that group, how do they go about finding out when the vaccine is available for them?
So older Mainers who are considered to be part of 1B, and what that age cutoff is yet to be determined. We're taking a hard look at the epidemiological data to figure out what the best way to approach that is. But the way that those folks will likely find out will most likely be through their healthcare system. That being said, we're trying to make as many options available for all of the folks in 1B, be they older Mainers or frontline workers, where they can get vaccinated. But where they will find out is perhaps partly through these briefings, where we will make those announcements to let folks know that their time is ready and here's how they can access it. But more granularly, more tactically, it's most likely that they will receive outreach from their healthcare system, from their provider, who may have, for example, I'm just speculating or hypothesizing, who might be able to query their their electronic medical record system and say, here are all the patients I care for who are X age and over. I'm going to send them an email to let them know to start scheduling. We know that is a question that is on everybody's mind. It's not so much who might be in that group, but how are they going to know? And then where do they go? We're trying to think all of that through right now so that, if I may, we don't have some of the scenes that perhaps folks saw from other states with people literally sleeping in their cars overnight, waiting for a spot to get vaccinated. We think we can do this in a more orderly and systematic fashion.
Thank you.
I'm going to turn it over to Bob Evans at News Center next.
Good afternoon. I wanted to get your thoughts on questions that have come up recently over the second vaccine that ask, with the first vaccine for many people running behind, should we delay the second vaccine for people in order to get more people started with a vaccine?
You know, I'm aware that at least one country has opted to go in that route to some degree. Bob, I will echo what officials from the U.S. CDC, as well as I believe Dr. Fauci, but I know a senior official at the U.S. CDC has addressed this, and the answer is probably not at this time. So first of all, we don't know what the longevity of that first dose is. And all of the clinical trials that have been done on the vaccines we have right now utilized a 2-dose regimen. We would be rolling the dice if we decided to only utilize that first dose, because we don't really know what the longevity of protection is. And if that longevity of protection is not what we want it to be, if it's not, for example, what other country has speculated it might be, they could actually undermine all of the efforts that they've taken to date. Not only would they not have vaccinated anybody because that immunity may have worn off, they would have to start the entire process again. My view is that we follow the science as we know it, and the science as we know it utilizes studies in which individuals were given 2 doses. One can speculate about whether and to what extent there may be effectiveness from 1 dose, but it's just that, it's speculation. And folks who've tuned in to these briefings for the past several months know, I don't try to do science policy by speculation. We go with the data that we've got, and the data that we've got suggests that 2 doses are the way to get to maximum protection.
Understood. And I lost the signal briefly, and I'm not sure if this is what you were referring to with Patrick, but out of the people who are eligible to be vaccinated in phase 1, how many people, or what is the percentage of people would you say have decided to opt out of getting the vaccine?
Sure. So Bob, until we are through phase 1 and have the complete denominator of individuals who were offered the vaccine and who declined it, it's going to be difficult to say. You can't really base that on how many were eligible, because again, hospitals have been, we've advised hospitals, for example, not to vaccinate all their staff on one day, because if a few of them develop a mild fever, that has implications. So it won't be until all of 1A we've gone through and we have an exact tally on how many were offered and how many declined that we'll really know. What I've got right now are qualitative reports from hospital medical officers and those who are running their vaccination programs, who report that at the hospital level, uptake has been high. Again, qualitatively, almost anecdotally, it's been north of 70, 80, high 80s%. Those are good numbers. Would I like them to be higher? Absolutely.
Thank you.
I'm going to turn it over to Amy Brown at WERU next.
Thank you, Dr. Shah. We're about a week and a half past the Christmas holiday now, so should we be seeing the surge in cases by now if we are going to related to the holiday and travel? And if there is not another surge from that, do you anticipate that case rates and hospitalizations may start going down? I know the whole possibility of that other highly transmissible strain comes into the picture, but if it doesn't for a while, might we expect to see things getting better here in the next few months?
Sure. So Amy, in terms of any potential increase in cases related to the holidays of the past 2 weeks, it still is, we are probably in the next few days going to be entering the period at which we would see any such increase if it were happening. 10 days is really the front end after a large series of events, be it one large gathering or in the case of Christmas, Hanukkah celebrations, numerous small gatherings all happening in parallel. 10 days is really the front end of when we might see any putative increase in cases if it's going to happen. So we really want to see what this week brings and what the data show before we go, before I sort of get a sense of what's happening. Similarly, with respect to the next several weeks, if there is not an increase related to those holidays, that's a great thing. We've seen some early data on reductions in travel. Those are encouraging. So perhaps there will not be an increase. But if there's not, it doesn't really tell us much because we've still got to keep our eyes open for just more transmission happening irrespective of those holidays. As I mentioned earlier, the numbers of new positive cases, test results, has been creeping upward a little bit. So I think the bottom line answer, Amy, is that right now it's too early to tell, and it's hard to speculate on what might happen given all these other concerns around the new strain.
Okay, thanks. And a question from a listener who's wondering if a group of friends who have had the vaccine want to gather together, can they, assuming they've had both doses, when they've had both doses, can people from different households who've received both vaccines gather together unmasked inside? Can they hug?
That's a great question. It's one that speaking with someone earlier today about. The answer, Amy, is that we hope at some point that will be the case, but because the vaccine is no medication in the history of recorded medications or vaccines is 100% effective. And also because we don't know with certainty whether the vaccine eliminates or reduces your likelihood of harboring or transmitting the virus, even amongst folks who have been fully vaccinated. Of course, I want folks to start gathering. We all crave that return to normalcy. But for now, I would recommend after folks have been fully vaccinated that they continue when they get together to stay spaced out apart and keep their masks on just to be safe.
Okay, thank you.
Let's hope that changes. But for now, that's what the best data suggests. I'm going to turn it over to Joe Lawler next.
Yes, hi. A couple of things. We were talking about the data following the holidays. The data in the last few days following New Year's Day, is there any still effect of lagging reports coming in from labs that might have reduced numbers, or do you think we're all caught up?
Joe, the answer there is that there are still some lab reports that we are working our way through from the holidays and others. We've also seen a reduction in the overall amount of testing, specifically the day before the 23rd, 24th, and 25th, and then the 31st and 1st. Laboratories, healthcare providers were just not online with testing. And so although our laboratory was open, we know that testing volume overall went down on those days, as one might expect. So for me, Joe, it's still just a little too early to get a clear sense of what may have transpired over the past 2 weeks. Our epidemiology team we've talked about that pretty extensively internally. So I know they are highly attuned to trying to look for signals in the data that might be suggestive of household level transmission, small clusters, for example, all of whom might have the same address, things like that. We're very much on the lookout for that. But at this juncture, it's just too early. The crystal ball is still hazy.
Okay. And then another question I had is, I know there's been many questions and discussion about what, in phase 1B, people 75 and older, and I think you just mentioned that age cutoff may be somewhat different. But also, I'm wondering, is there any discussion about prioritizing groups within 1B? So in other words, if you're of a certain age, you may get the vaccine, even though you're in the same phase as, say, an essential worker, that you may get the vaccine before that essential worker, or maybe that there might be subcategories within essential workers, like some essential workers, depending upon what job you do, may have more contact with the public than other jobs. Is that part of the discussion?
Yes, the answer to everything you said, Joe, is yes. That is almost exactly where the discussion is right now, in fact. So both on what the right epidemiological cutoff age should be, and then within that, let's say it's X, and over X is where we go. Now within that over X, maybe we start with an even higher bracket of age category and then move a little bit lower. That's one concept of operations. Similarly, exactly as you laid out, even within those frontline workers, are there some frontline workers who are even more frontline than others, and thus may be at higher exposure? And maybe in similar fashion, everyone is part of 1B, but in terms of where we'd like to start our efforts, recognizing that we got to start somewhere, maybe we start with the groups that are within 1B, the very oldest, or the very, very highest risk of exposure, and then move similarly as we did with 1A, where we started with a tight concentric circle of emergency department, ICU, and EMS because of their exposure, and then moved outward in concentric circles. We are working on how we can do or think about something almost identical for 1B, using those same metrics, exposure risk, so on and so forth. So that is exactly right, Joe. No decisions have been made. In addition, we are still, we're in week 4 of 1A, and it's going to take us still several more weeks just to move through 1A, but that gives us time to plan and prepare for 1B. Again, no decisions have been made, but that is almost exactly where the conversation is right now.
If I could just squeeze something in real quick. I know you're talking about vaccine supplies, and it's not coming in as quickly as you would hoped. But is there a number for, like, say they do ramp up production, say we start getting, instead of 15 to 20,000 doses per week, say we start getting 20 to 30 or 40,000 doses per week. What number really makes a difference there?
Good. So I don't want to, not going to nerd out too much on this, but spent a lot of time over the weekend working on models to help think through that exact same thing. I'm not going to read off a litany of numbers because, boy, that's not a good way to answer this question. Let me say this, Joe. First of all, my team and I have been thinking about that exact thing, which is essentially, I've talked about how right now we are supply constrained, and as a result, the vaccine is a precious resource. But what does it mean to not be supply constrained? And the answer, Joe, is that it depends on where we are in our different phases. Not being supply constrained in phase 1A means something different than what not being supply constrained in 1B, 1C, and subsequent phases looks like. So there is not a single number. What I will throw out, though, is one number that seems to make a difference in the way that the trajectory of vaccinations goes is, at a minimum, 50,000 doses per week. Once we are dependably, reliably at that phase, a lot of the other models change in terms of constraints. Is that the only number? No, absolutely not. And there are other models that suggest that it's not until we get to many tens of thousands of doses more per week, 60, 70, 80,000, that we start really lifting those supply constraints. But until we're getting at that 50, we're not really talking turkey. I'm going to turn next to Brian Sullivan at WABI.
Thanks, Dr. Shah. Just a couple of asking for a couple updates on some outbreaks that you'd reported on previously, either from you or maybe an email from Robert, but one on East Side Rehab in Bangor and then Katahdin Healthcare in Millinocket.
Sure. The latest numbers that I have, Brian, on East Side Rehab are at 58, but I'm going to we will triple check to make sure those numbers are the latest numbers. Similarly, with respect to Katahdin Healthcare, the latest number that I have is 34, but there's been a lot of activity with both of those investigations. So if those numbers are different from what the latest is as of this morning's work, we will keep you updated. We'll send you an update.
We've been speaking with some officials in and around the MDI area, and they just are reporting some outbreaks and disruptions at schools and things like that. Can you give us a little glimpse into what's going on in that general area?
In recent weeks, we have seen an increase in cases in the MDI area, really across Hancock County. To be sure, we've seen an increase in cases across the state. I talked a little bit earlier about Aroostook County, not in the same neighborhood, but we've seen an increase in cases down east, Hancock County, Aroostook County, Western Maine, all across the state. We have concerns around where things stand in Hancock County because we have detected some outbreaks there, but to be straight, we're also deeply concerned about other counties, Aroostook County in particular right now, given the high number of outbreaks, as well as, for example, the lack of backup staff in many of those facilities. So, the better way I think I characterize this, Brian, is that we're not seeing something localized or specific to one part of the state. We are seeing it all across the geography.
And just real quick, if I could, you mentioned a lack of some of the doses of vaccine or less than you thought. Has your original plan, have you been forced to pivot in any way or change the way that you've delivered these vaccinations from what you originally laid out in the path we've followed instead moving forward here?
We have, and I won't talk in the abstract. I'll give you a very concrete example of one way in which the changes relayed to us, given to us by Operation Warp Speed, have had to change our approach. 2 weeks ago, for the doses that arrived in week 3, last week, although we received net about 350 fewer doses, the composition of those doses was much different. We received several thousand more Pfizer doses and several thousand fewer Moderna doses. Even though, again, net, it was only a change of 350, the significantly more numbers of Pfizer doses and commensurately fewer Moderna doses had a significant operational impact for us. We had to pivot almost immediately because the Pfizer vaccine can only go to places with ultra cold storage, i.e. hospitals. Whereas the Moderna vaccine, which we had been hoping for, could have gone to more rural areas. As a result of that, we had to change our concept of operations within an hour or two and furnish the hospitals with Pfizer vaccine, which is great. They plowed through it and are using it, but it did mean that rural hospitals without ultra cold storage are getting more of their doses this week rather than last week.
Thank you.
You know, just to be clear, this type of pivoting, this dynamism, this changing on the fly, if I may, it's what we do. This is what operations in a pandemic, in an emergency are. This is what we will continue to do. But secondly, we will have to keep doing this. Even though we may eventually achieve some degree of stasis with respect to vaccine supply, what we've learned so far is suggests and is indicative of the fact that these quick pivots will continue to have to happen. I'm going to turn next over to Caitlin Andrews at the BDN.
Good afternoon, Dr. Shah. Happy New Year.
Same to you.
Thank you. I have a question kind of about contact tracing. The state having to have kind of scaled back to keep up with like the numbers and having people like text folks. How confident are you about how accurate the state's total case numbers are? And can you talk about like how important contact tracing is now at this point in the pandemic as opposed to testing or vaccination?
Yeah, thanks for that question, Caitlin. You know, we have tried to keep, you know, we've tried to continue turning up the dial with respect to the number of staff that we have who are working on case investigation and contact tracing both, as the number of cases has gone up. We'll actually try to get for you, Caitlin, the exact number of staff we have. I believe it's on the order of 160 or so, 165, who are working on case investigation and contact tracing. They are still of importance. Make no mistake, that's why we haven't done what other states have done, which is, not exaggerating, they've basically stopped much of those work streams. In many states now, if you get diagnosed with COVID, you may not even get a call from the health department. You may just get a slip of paper get handed to you with your lab result that just tells you what to do. In Maine, we didn't think that was good. So what we've put into place in addition to what we were previously doing are a few things. The first is that if we have a phone number on file, every lab result that gets reported to us gets an immediate text message within about 24 hours of that lab result being reported to us. And it's a simple text message that just says, we've gotten a positive lab result at this number. Click here to find immediate information on how to isolate and how to stay safe. We've also developed a separate team of folks that also, not instead of, but in addition to the text message, call folks to just check in with them, see how they're doing, answer any questions. If the individual who's positive falls into one of the groups that we are focused on, those who are over 65, over 49, and those who are under 18, they subsequently get a call from a case investigator who walks through everything, as well as get connected with our contact tracers. So we haven't abandoned any of those things. And as a result, we feel like we have good insight into where the pandemic is right now, but because of those constraints, we don't have the insights that we may have had back in, say, October. But all that being said, we have such a high number of cases that we still are able to get a pretty global view. Those things remain of importance. The question that's on our minds right now, Caitlin, is that if we go from not 300 to 600 or 700 cases a day, but from 300 to 700 cases all the way up to 3,000 to 5,000 cases per day. Seems crazy, but hey, with these new variants, who knows? Where do we go from here? How do we plan and prepare for a possibility of having thousands of cases per day, not hundreds? That's what our epidemiology team has been talking about right now.
Okay, thank you. And just to kind of reiterate a little bit more on this question of the uptake, like how are you kind of calculating that 70, 80% figure? Can you just explain that a little bit more?
So that figure, to be candid or to be clear, comes by report from medical officers, chief medical officers at the various hospitals that have been themselves vaccinating their own staff. So we do not, at our level, have insight into, for example, how many people were offered a vaccine and accepted it or declined that. That's really something more the hospitals and clinics would have. And those numbers come from my conversations and my discussions with the medical officers and the CMOs of those various hospitals. They calculate it by just that mechanism. If they've offered the vaccine to 50% of their 1,000 staff or 500 people, and 400 of those 500 who were offered it accepted it, that's where we get that 80% number from. But really, it won't be until we look back on phase 1A and we tabulate exactly how many people in 1A were offered the vaccine, how many accepted, how many declined. That's really the point. Only in retrospect will we know what the total uptake rate was. Doing it in the midst is very difficult because scheduling and so on and so forth. So those numbers are highly preliminary and again, just relayed to me anecdotally in my conversations, not part of any official reporting.
Thank you.
I'm going to turn over to Evan Pop next.
Hi, Dr. Shah, thank you. So we've seen a lot of stories nationwide about how the vaccine distribution effort is going more slowly than hoped for. And you said that Maine has not received as much vaccine as it had hoped. I was wondering if you could kind of put that in a little bit of context and share how Maine's speed of vaccination and supply of the vaccines compares to the rest of the country.
Sure, Evan. I am happy to do so. I don't usually go into state-by-state comparisons, but since you asked, based on data that have been tracked by the US CDC as well as by another news organization, I am honored and pleased to report that Maine is faring well relative to other states on at least two important axes. Number one, what percentage of our overall population have received at least their first dose? And in Maine, as of this morning, I believe that number was about 2.7%. Again, relative to other states, that puts us at the top of that league table. The other metric is of the vaccines that have been allocated to the state, what percentage had been administered. And I don't recall what that number was as of this morning. I'd have to go back and I don't have that at the top of my notes, but again, relative to other states, Maine was at the top of the league tables there. Now, the reason I don't like to talk about these things so often is that we are just starting this race, and those things can change, and they will change. It's a little bit like getting in your car and going on your way to work and looking down at your speedometer right after you pull out of the driveway and seeing that you're only going 12 miles an hour and saying, oh my God, it's going to take me 8 hours to get to work. Well, no, we know you're going to speed up. The vaccination is the same thing. We know the process will speed up significantly as states as well as vaccinators, hospitals and clinics gain competence and fluency with administering thousands of doses of vaccine. The other thing, Evan, I will share is that although velocity is very significant, equity is just as significant. And we've got to always ask, not just how many people we vaccinated, but did we vaccinate those who have borne a disproportionate share of the disease or who are at the highest risk? We always ask ourselves those questions as well. And the news site I mentioned, I don't mean to be opaque about it. It's Bloomberg, which has been tracking these things based on data that are reported out by states.
Great, thank you. And so kind of another question along these lines, talking about the vaccine supply being limited. And hypothetically, if that supply were to get larger, what are the processes in place to keep up with the supply? And I'm just sort of wondering, how long would it take to ramp up the logistics needed to distribute that larger supply?
Sure.
I guess.
Yeah. We're working on that right now because generally speaking, there are multiple channels, all of which we want to activate in order to get folks vaccinated. Those channels include places like hospitals, which are currently doing extraordinary work getting folks in their ecosystems and in their communities vaccinated. Others include places like pharmacies, retail and other pharmacies. Your primary care physician's office is another venue. We're also looking at other concepts of operation. For example, as was done with the H1N1 mass vaccination, can we work with, say, large employers to offer vaccines in the workplace? Similarly, can we work with other partners to offer larger scale vaccination venues as well? Those things, of course, take time. There are some unique findings with respect to COVID vaccine that differ in material ways relative to other vaccination efforts. Number one, the storage requirements. Most places don't have a -80 freezer that can store thousands of doses on hand. That changes the logistics significantly. Number two, as we're learning, the need to observe folks for 15 or 30 minutes while simultaneously avoiding crowds. You can't have a mass vaccination or vaccine clinic where you've got 300 people jammed into a line in an indoor space, because then you might have an outbreak, which completely undermines the purpose of asking folks to come get vaccinated. So we've got to be extra solicitous about some of these operational concerns because they differ from prior mass vaccinations in really significant ways. If we're not careful with monitoring, then folks may have reactions that go unnoticed. If we jam too many people in one place, we could have an outbreak. If we don't care and provide for cold storage, vaccine may spoil. So these things can and will take time to do correctly. Again, I was surprised by pictures I saw over the weekend. And to me, those are examples of what can happen if you don't take the time to plan out not just who is vaccinated, but how to vaccinate them in an orderly and safe fashion. We've got to keep those principles in mind just as much as we do figuring out who's next.
Great. And just one last question, if I may. We've talked a lot about the issue of vaccines in prisons and jails. I know that you said before Christmas that you were unsure when the vaccine would reach people in that category. I was wondering if there had been any update in the time before Christmas and now, if you had any other light to shed on that situation.
No, sort of similar to what Joe Lawler raised. That's another topic, an item that's under discussion right now, but no final decisions have been reached.
Thank you.
I'm going to turn it over to Mel Meyer next.
Thank you, Dr. Shah. My question first is, given the state is seeing elevated cases, is it recommended to go back to in-person learning? Is that safe or advisable? Should school districts be putting caps on remote learning? I'm thinking of one school district in particular.
Mel, one of the findings of the pandemic, that to the extent that there has been something that has been surprising and in a good way, has been the fact that owing to the hard work of teachers, staff, faculty members, as well as students and parents at schools, there has been remarkably little transmission of COVID-19 in schools. Have there been cases among students and teachers and staff? Absolutely. Have some of those cases clustered, so we've determined that there might be an outbreak? Absolutely. But the question on the table is there a risk of ongoing, sustained, significant high-level transmission of COVID-19 in schools? The answer to that, thankfully, has thus far been no. Have there been some cases of transmission? Absolutely, no doubt about it. But has it been so significant as to give or create pause in, say, the safety of in-person education? Not to my lights. Now, this isn't an accident. The reason that schools are safe has nothing to do intrinsically with the nature of school. It has to do with the hard work and dedication that teachers, school nurses, school staff members, and parents and students have put in to stay masked up, to stay distant. To me, that's one of the positive findings that was unexpected about the pandemic.
And then I have separate questions. We're getting viewers contacting us wondering about businesses not necessarily following up when there's COVID cases. They're concerned that they're not being properly contacted and they are worried that they might have been exposed. How should people report this? Is the CDC following up to making sure that businesses are properly notifying people of potential exposures?
So it does depend on the nature of that exposure, when it occurred, how it may have occurred. Where possible, if a business is aware that there may have been an exposure, a widespread exposure, we do recommend that they notify those who may have been in the store. If it's a grocery store, that's a difficult thing to do. Generally speaking, if folks are wearing face coverings, as they should, and are maintaining physical distancing, the likelihood of needing to be notified goes down, thankfully, but it doesn't fall to zero. So what we recommend is for those who know, for example, that there has been an exposure, say at a restaurant, that the restaurant notify those who were in close proximity and do essentially what amounts to that kind of contact tracing. So those who may have been exposed are notified.
And then, sorry, real quick. So what should people do then if they are worried that they've been exposed but have not been contacted? Should they still follow up? What should they do then next? Should they be getting tested then? What should they do?
So if anyone believes they may have or could have been exposed to COVID-19 in any setting, at a restaurant, at a store, at work, at your friend's house. The best things for them to do, number one, stay in quarantine. Do not go to work, do not hang out with others, do not go out. Number two, arrange to get tested. There are now at least 30 testing sites for PCR, as well as a number of other tests across places across the state where individuals can and should call, make an appointment to get a PCR test. Make sure that while they are waiting for that test result to come in, they remain in quarantine. If it's positive, well, it's kind of what Caitlin and I talked about. There will be appropriate notifications made. If it's negative, that provides an additional blanket of security. I'm going to turn now over to Dustin at New England Cable News.
Hi, Dr. Shah. I understand the hesitancy to delve into this too deeply too soon, but for clarity, does the data we've seen from Bloomberg perhaps suggest Maine is getting shots into more arms more efficiently than other states, at least for now?
I hear where you're going, Dustin, and I would love nothing more than to have that answer be an unequivocal yes, but it's just too early to tell. We are, again, we're just pulling out of the driveway and looking at the speedometer. It's too early to tell at this time. I hope the answer will eventually be, looking back, an unequivocal yes. It's my goal, but at this time, I can't say that.
And then is there anything that makes Maine's vaccination plan more unique or more efficient in getting shots to people faster?
Yeah, similarly, again, it's just too early to tell whether any of the unique facets of our plan are making these operational changes or making the difference. I will say our plan was deliberately designed to prioritize velocity and equity. So for example, one thing we took great pains to do was early on and to this day, not provide facilities more than they could administer in a week. If a place can only administer 100 shots a day, we had no business giving them more than 700 doses at a time. That way there was not in virtually anywhere that, at least initially, we tried to avoid vaccines sitting on the shelf. Similarly, we've told folks who have received vaccine, hey, if you've got vaccine sitting on the shelf, let us know. We will come and get it and move it to other places that can use it today. So again, we've tried to prioritize throughput, velocity, because that really is one of the two goals right now, velocity and equity.
So it sounds like at all costs, you really want to avoid the line situation that the images are showing from these other places.
Yeah, I mean, lines are just not efficient in any way, whether it's a line of vaccine on a shelf waiting to be administered or a line of people waiting to get vaccinated. Now, of course, there is a metaphorical line, that of people across the state who are waiting to get vaccinated. That's an unavoidable one. But for example, as we talk about moving people into vaccination, my hope is that we do not have legions of people waiting in their cars overnight for long periods of time. Rather, we hope to be able to schedule them so that they don't need to be crowded in a confined space or even on a sidewalk for long periods of time, let alone in their cars for long periods of time. Our goal is to be able to space them out and provide more clarity so that that customer experience of getting in and getting out is as smooth as possible. It's going to be a challenge, make no mistake. Lines are unfortunately part of where we are anytime we're talking about a situation where demand greatly exceeds supply. But how we modulate that line to make it a safe one, that's our goal. And I'm going to turn it over to Steve Missler to wrap us up for the afternoon.
Thanks, Dr. Shah. Just building off the couple of questions about notification of vaccine and administering it, to prevent lines, I know that some states have instituted basically pre-registration programs online. Is that something that the CDC is considering?
100%. So, Steve, I mentioned a moment ago at least 5 channels that we envision vaccine flowing through, doctors' offices, pharmacies, hospitals, but then there may be others as well. For example, larger scale vaccination sites, and perhaps even ones at sites of work, provided they are sufficiently large. And for many of those, we are working on utilizing a front-end tool that will allow folks to sign up online, but not just sign up. Signing up is you know, a lot of things can allow you to sign up online, a restaurant reservation system. What we really want to do is try to get as much of the pre-work done beforehand: consent, registration, time slot, whether there's any kind of billing or insurance registration with Medicare, so on and so forth. We want to front load all of that. So when people arrive at their time for vaccination, much of that has already been done and already in the system. So folks can get in and get out, obviously in service of keeping exposure risk as low as possible.
Would that mean potentially, I mean, I guess would that registration, for lack of a better term, would that occur through the state? And then they would say, okay, here's your time and you're going to go to this location, or might it differ depending on your situation?
It will differ perhaps based on your situation, but more likely based on where your site for vaccination is. If what is the most accessible to you is to going to your neighborhood pharmacy for your vaccination, most likely you'll use their system for scheduling a vaccine, much as right now, for example, Walgreens and CVS, you use their system to schedule a COVID test. Similarly, if the best and right site for you is in your doctor's office or at a federally qualified health center, you're most likely to work directly with them to schedule your time. So it will depend partly on where you are, but also on which channel you are using.
And just real quick, we can wrap this up. In terms of employers, you mentioned a couple of times now that if the employers are large enough that they might, I'm assuming what you mean here is that they would actually have vaccinations occur on site. And if that's the case, would they be responsible for hiring the vaccinators, or would that be something that the state would work with them to do?
So the former part of your question is yes, and I want to stress that that is purely just based on a model that was used during the H1N1 influenza situation. Whether that works for COVID vaccination, we've got to work through some of those details that I mentioned in connection with some of the previous questions: spacing of people, waiting so that people can be monitored, scheduling, things like that. I think there's good reason to think that that employer-based model will work, but it may not work for every site. I just want to be clear about that, and no final decision has been made there. As to your particular question regarding who staffs that, again, no final decisions have been made there. It will again depend largely on the type of location. Some employers have very robust worksite wellness programs that may be able to accommodate this. And what we would do is furnish the vaccine. Others may need a list of places to call, and others may need more support from us. Whether we're able to accommodate that really will depend on the particulars of the employer. Again, it varies so much based on the employer, their physical layout, number of employees, anticipated throughput. A lot of variables go into that equation.
Thank you.
Well, thank you all for your questions this afternoon, some of which have come from our colleagues in the media, others of which are ones that you have directly sent to us here at the Maine CDC, either to me, to my team, on social media, and other venues. Please keep sending us those questions, either about the vaccine or about vaccination. And from time to time, I'll take some time to make sure that all of you who are watching, are getting your questions directly answered. As I wrap up for the afternoon, I'd like to take a moment again to thank all of you. Let us hope and wish that this year is truly a happy new year. So with that, thank you all for your time this afternoon. As always, please be kind, take care of one another. We'll talk again on Wednesday.